Hello friends. Um so guys, this is Dr. T and welcome to this tutorial where we're gonna be doing something in urology now. So I think this is our first urology video. So here we'll be talking about male urethral syndrome, also known as MUS. So guys, it's very important it's not something that we always do, but it's very important to try and stick to the current terminologies, so that it becomes easy to communicate with other people. So the term STI is no longer used. What previously was called or was termed STI is now called male urethral syndrome. What is male urethral syndrome? So it's that male patient who comes in with a history that they have dysuria, which is discomfort on maturation. So as they pass urine, they feel discomfort. Is that male patient who comes in and say, look, when I pass urine, I get a burning sensation, or I have pain as I urinate, or I feel itching or pruritus as I urinate. Is that male patient who's gonna come in and say, you know what, when I urinate, as I pass urine, my urine is cloudy, or is milky, or you know what, I saw some white stains on my underwear. Then you know something is happening there. On top of that, yes, you will take the history, ask about the duration. It's normally about plus minus 7 days post unprotected intercourse. Protected intercourse, right? Yes, they will tell you that they are sexually active, they didn't use a condom, or they don't use a condom, things like that. Yes, you're gonna take the history and you are gonna talk about their past medical history. The most important, the most important thing when it comes to the past medical history is the HIV status. Yes, you can talk about the other comorbidities, talk about other things, and all of that. But this one becomes very important because it's an opportunity to talk about condoms, to counsel the patient about condoms, counsel them about HIV and all of that, and encourage them to actually go on and test if they don't know their status. Okay, that's fine. Now let's talk about the physical examination. So physical examination, and when you get someone who has got these symptoms, and as a doctor you are suspecting that they are talking about male urethral syndrome, you want to ask them about their, so the sexual history becomes very important here. Sexual history, basically how many partners, the last time they had intercourse, and stuff like that. And yes, it might be embarrassing to ask, but the type of intercourse they have, is it anal, is it oral, is it that, is it that, yeah. Sometimes we have to ask embarrassing questions as doctors. It's just part of our work, yeah. So fine. So and then as you examine them, you might look for other clues that might suggest that this patient has got stage 4 AIDS, like those features. Look at them. Are they well nourished? Do they look sick? Do they have any lymph nodes? Things like that. But what you want to get at, the system of interest, is the genitourinary system. So what you want to do there is you want to examine their genitalia. Check if they've got any obvious sores. You know, when we are going to talk about syphilis, they talk about chancre or chancroid. Chancre is caused by Treponema pallidum. Chancroid is caused by I think it's Haemophilus ducrei. Then you look at if they've got any, you look for ulcers. Let me put it that way. Ulcers that they might be having. Look at any nodes that they might be swollen. Look at the whole penis. Look at the glands. Are there any ulcers? Is there any pus? You can even try and milk to confirm if there's any pus. Look at is it mucopurulent, or is it just a purulent, or there's no pus at all. You might want to also check if there's any edema around there, and check if they've got, because the type of ulcers that you might find can also give you a clue. For instance, if someone has got herpes simplex, they will have those blisters in the genitalia, and stuff like that. So basically you do a proper examination and even try and milk if you can. And also sometimes looking at their underwear, you can see some stains there that will tell you that they actually have a discharge, right? Okay. So now, why was it necessary to move from STI and call this MUS, which is male? There is no patient that should have this kind of an assessment. They should not. There's no patient, because I think this thing takes away the dignity of the patient first of all, and also not all discharges. Okay, let me just put it this way. Putting an STI there is an embarrassing kind of a diagnosis. I'm glad that whoever came up with this thought about MUS and call it MUS. I think it's more it's a more of a dignified way of putting this. But what I want to talk about is, when you talk about MUS, obviously you cannot differentiate the cause based on how the patient presents. Obviously, if they've got a bending of nutrition, there's no discharge, they've got blisters, you might think, okay, it's herpes simplex. Or if they've got just like a purulent discharge. You might think, okay, it's gonococcal, but you cannot be sure. You can't be sure. So and also someone can present with urethritis not because they were having any intercourse. Maybe the previous or last week they had a catheter that was indwelling. Now this is what they have, and that has got nothing to do with intercourse. So yeah. Anyway, so when you talk about MUS, there are two classifications. It can either be gonococcal, or non-gonococcal. Non-gonococcal, right? If it's gonococcal, it means that the first thing is clinically you should have a purulent urethral discharge. Urethral discharge, or just a purulent discharge. And it means the pathogen involved is Neisseria gonorrhea, which is a gram-negative bacteria. So the gram stain can actually pick this up. So if you have got, which we never have, if you have got a microscope, you can quickly do a swab and look under the microscope. If the gram stain becomes negative, then you know it's gonococcal. But if it doesn't give you anything, it's probably non-gonococcal. So the causes under non-gonococcal is things like chlamydia, trachomatis, things like mycoplasma, most common, mycoplasma genitalium, and also herpes simplex virus. So yeah, those are non-gonococcal, and it's important to understand this because the treatment is related to this. The interesting thing is that the way they present bending and maturation, dysuria, it's not different. They present the same. But it's after actually doing a swab to see, oh, this is gram stainable, this is not gram stainable. Oh, I think it's chlamydia, I think it's that. Okay, so when it comes to the management, drugs that cater for gonorrhea, at this present moment, the guideline that we use is we give ceftriaxone. If a patient is less than 150 kgs, they get 500 milligrams. I have seen people getting 250 milligrams in other guidelines. I am stat. That one caters for the gonorrhea. And then this side, there isn't much that you can actually do for the herpes simplex, but you can give a cyclovir. But the most common ones that are catered for in the guidelines is chlamydia, trachomatis, and mycoplasma genitalium. The drugs that you give there is, you give azithromycin, (500 milligrams), as a stat dose, and that's oral. Or you can give doxycycline. Doxycycline 100 milligrams orally BD for 7 days. So guys, this thing of giving of prescribing flagyl or metronidazole for MUS is not in the guidelines, should not be happening. This is what you should be giving, and this you choose. Do you want to give this or do you want to give this? But literature says that the most appropriate drug to give is azithromycin. But if you don't have, you can put a patient on doxycycline. And then the patient goes. In the event that, then before they go, the most important thing is that this patient needs counseling. Counsel about HIV, barrier, contraception use, which is condom, and how do I put it? About sexual partners, right? Partners. Because the fact that they've got these symptoms, people who have this, 90% of them, it's sexually transmitted. That's why we have to talk about these things. And if you can get them to do a HIV test, please, they should get it, because HIV, we know it is a sexually transmitted disease in about 95% of the times. So I've had patients that would come in with MUS, and then when we test, when they agree we test, bam, they're HIV positive. So it's important, guys. It's important. Let's not get excited when we start this and forget about this. So one thing that is important that this patient should know is that they should not be sexually active without a condom for at least 2 weeks. Because if they are sexually active within 2 weeks, first thing is that they will spread the infection, or they will get reinfection, and your medication, you won't know whether it's working or whether it's not working. That's one. And also, those are two things that I wanted to say. And another thing is this: the partner that they have should also be treated. Should be treated. In some cases, the guy is given medication to go and give the partner. In some cases, the partner is called in to be examined, and then they are given treatment. So those are the two ways it can be done. Yeah. So guys, that's just a small touch on MUS. I don't think there is much we can talk about here, but it's a very important topic. We meet a lot of MUS in the clinic, so it's important to know what to do. So the treatment for MUS is ceftriaxone. I know the guideline that we use is 250 milligrams instead, but literature says that you should give 500 if they are less than 150 kgs, and then 1 gram if they are more than 150 kgs. That caters for the gonorrhea. So in the event that you don't give a patient ceftriaxone at all, but you give them the azithromycin, it means that the gonorrhea has not been catered for. So we need to give that. And then azithromycin caters for those two: chlamydia trachomatis and mycoplasma genitalium. And then if you don't have, you give the doxycycline 100 milligrams per OSPD. Herpes simplex, you can give acyclovir which can be 200 or 400 milligrams. So even though it is a least common cause of MUS, but it's still possible. Yeah, guys, thank you so much.